Welcome back to Pathagonia, everybody. So today I want to try something a little bit different. I wanted to do a practice run for my journal club article that I'm going to be discussing with the department on Tuesday. So I'm going to talk a little bit about this article that was in the New England Journal of Medicine, and it's called Chronic Traumatic Encephalopathy in the Brains of Military Personnel. So a little bit of background on me. I went to Florida Atlantic University and I studied neuroscience and behavior when I was there. And while I was there, I volunteered in a neurobiology lab. And at that time, while I was working in Dr. Guthrie's lab, or volunteering, not working, this movie by Will Smith came out called Concussion. And it's based on a true story. Excellent movie if you haven't seen it. And it's about Dr. Bennett Omalu, who's pictured over here with Will Smith. And it's about his discovery of CTE, or chronic traumatic encephalopathy, in American football players. And it seems like an appropriate time of year to go over this, given that college football is kicking off and the NFL starts, I think, next week. So being in the military, obviously I care about the implications of this paper for the military, and then I'm also a football fan, and for those reasons I thought it would be an interesting article to talk about. So pictured here on the right we have Pittsburgh Steeler Mike Webster, and I'll talk a little bit more about him later, but he was actually the first American football player that CTE was discovered in his brain post-mortem by Dr. Bennett Omalu. So the first few slides are just a little bit of background on CTE and the pathology that you can expect, and then I go into the paper itself. So a few of the slides are directly from Dr. Ann McKee's lecture. I'm not trying to claim this as original work. I just wanted to share this material and open up discussion and talk about an interesting topic. So this is actually a paper by Dr. Bennett Omalu, and this is where he cites his discoveries of CTE in an NFL player who was Mike Webster. So a little bit of history of CTE. It was first described in 1928 when Dr. Harrison Martland talked about a group of boxers that had punch-drunk syndrome. And then over the next 75 years, a lot of researchers reported similar findings in boxers and other victims of brain trauma. However, in 2005, the pathologist Dr. Bennett Omalu published the first evidence of CTE in an American football player, as I previously mentioned, and that's Pittsburgh Steeler Mike Webster. So what is this disease? What is CTE? Well, it's a neurodegenerative pathology, and as the name would suggest, it occurs from chronic trauma to the brain, so repetitive head impacts, and this can include symptomatic concussions as well as asymptomatic non-concussive injuries, so those little hits on football plays where you're not necessarily knocked out, but you just are seeing stars a little bit, or you're kind of dizzy. Those adding up over time can still cause problems later in life. CTE has been diagnosed in American football, rugby, ice hockey, and the other sports listed, as well as in military service members and individuals that have head banging. And like many neurodegenerative pathologies, CTE can only be diagnosed after death by a post-mortem brain examination. It cannot be diagnosed with certainty during life, though various clinical symptoms can be seen, and you can indicate that it's likely that an individual may be suffering from traumatic encephalopathy syndrome, which is the clinical condition associated with CTE, and that's a diagnosis that can be rendered while a patient is alive. So two of the diagnostic features, and this is from Dr. McKee's work. So two of the diagnostic features of CTE are going to be perivascular phosphorylated tau deposition. So we can see these vessels here, and then we have the buildup of phosphorylated tau around them. And then also we're going to see lesions found at the sulcal depths. So in our brain, We remember from neuroanatomy that we have our gyri, or our ridges, and then our sulci, or sulci, that suck in. So that's how I remember it, the ridges, or the gyri, and then the sulci suck in. So you're going to have phosphorylated tau deposition around the vessels and then at the depths of the sulci. So Dr. McKee's work talks about the 4 staging system of CTE, and as you would imagine, stage 1 being the earliest, and then it progresses through all the way to stage 4. And let's say in a football player, someone that only played high school, could have one of the early stages. Not necessarily everyone that plays high school football is going to have this, of course, but just as an example, if someone has repeated head impact exposure and head trauma over years, maybe someone then plays college football and then gets into the NFL, that's over a course of a decade or a couple decades of their life, then you could potentially start getting into these later stages of this disease. And as you would imagine, with this phosphorylated tau deposition in the brain, that's going to impact the ability of neurons to communicate effectively. So there have been a few attempts to look at CTE in the brains of military personnel. So there's been like case reports and smaller studies, but this is the paper that I'm actually going to talk about by Premer et al. And Dr. Pearl out of USIS. So they looked at 225 brains, and I'm going to talk a little bit more about that. But overall, just a quick sneak peek, they discovered CTE in 4.4% of the brains they looked at. And from what I gather, that's slightly higher than you would expect from a non-military or just a civilian brain bank, but not abnormally high numbers. So some of the microscopic pathology that I already talked about that we're going to expect to see in CTE is that characteristic deposition of phosphorylated tau protein as neurofibrillary tangles or neuropil threads. And that's going to be arranged around small blood vessels and then at the depths of the sulci. And also you can get abnormal TDP43 deposition that is found in most cases of CTE. So finally, we're going to get to the paper, and it's by, as I mentioned, Premer et al. I apologize if I mispronounced that. And it is in the New England Journal of Medicine. I'll put a link of it in the comments, and it's free to read, excellent paper, very interesting, and highly recommend that you check it out. So a little bit of background on this paper and why they did it. So there's persistent neuropsychiatric sequelae that may develop in military personnel who are exposed to combat, and such sequelae have been attributed in some cases to CTE. And there's really only limited data regarding CTE in the brains of military service members, so they thought that this could be a contribution to the military population. And in the background we have a couple service members, and one you can see here is wearing an EOD patch. So that means that their job is likely explosive ordnance disposal. And then we have another individual in a bomb suit. So their job is going to means that they're going to be frequently exposed to blasts, which could potentially lead to traumatic brain injuries and other pathologies that could likely occur. So a little bit about the methods of this paper. So they looked at, as I mentioned, 225 brains from a brain bank that was dedicated solely to the study of deceased service members. And in addition to looking at the brain tissue, they also reviewed information retrospectively regarding the decedent's histories of blast exposure, contact sports, and other types of traumatic brain injuries and neuropsychiatric disorders. And then how they did it. So each brain in the study was fixed in 10% buffered formalin for 2 to 5 weeks, and then examined as a neuropathologist would in any case. And then the immunohistochemical analysis for phosphorylated tau was conducted, which was considered the essential diagnostic test for CTE. And that's what we see here in these images. This is phosphorylated tau deposition, which is what is staining brown in the background. So they did some other markers also, like TDP43, alpha-synuclein, and other various markers that you would look for deposition in the brain. However, those weren't reported because they weren't considered essential to diagnosis of CTE. And then as far as what they sampled, like how did they process and section each brain? So there was an average of 13 tissue blocks samples were taken from different regions containing cerebral cortex from one or both cerebral hemispheres of each brain, including from some or all of the following locations: frontal, temporal, parietal, and occipital neocortex, and then the entorhinal and parahippocampal cortex, as well as the cingulate cortex and insular cortex. So they really sampled throughout the entire brain, essentially. Moving on. So assessment for CTE neuropathologic changes was performed by the first and last authors, who were unaware of the decedent case histories and interpretations from previous neuropathological assessments. So that's important. So they were blinded. They didn't know anything about the decedent's history. They just were looking at the tissue, unbiased, and reporting what they saw. History of TBI was classified as a TBI that had occurred during the decedent's military or their civilian life. And then a military TBI was further subclassified as being impact TBI or blast exposure. So blast exposure, as a name would suggest, was being exposed to any kind of blast during their military duty. An impact TBI could be like walking around base and you trip over something and you don't have your helmet on and you hit something and you have a traumatic brain injury unrelated to a blast exposure. And then the history was considered positive for blast exposure if it included at least one specific report of being exposed to a blast, or if it was inferred by the nature of the military personnel's particular job in the armed forces. So if they were special forces or explosive ordnance disposal, EOD, then that was considered likely that their job would have required them to be around blasts. So results, what did the study find? So as I alluded to earlier, CTE was present in 10 of the 225 brains, so 4.4%. And half the CTE cases had only a single pathognomonic lesion. So not a lot of findings or neuropathological, like phosphorylated tau deposition or extensive disease, was reported. And then of the 45 brains from the decedents who had a history of blast exposure, 3 had CTE as compared with 7 of 180 brains from those without a history of blast exposure. So that was kind of confusing to me, that individuals without a history of blast exposure actually had more CTE than those that did have blast exposure. And interestingly, all brains with CTE were from decedents who had participated in contact sports. So I think that's a pretty stark finding and important to note. And here I just included a few tables from the paper. So this first one notes that we have individuals represented from all of the branches. We have Marines, Navy, Army, and Air Force. Although Coast Guard and Space Force was not represented, but the other branches were, the individuals were from the other branches. And then another thing from this table that I wanted to point out was that 4 of the 10 individuals diagnosed with CTE or were found to have CTE, the manner of death was by suicide, which sadly is not uncommon if you study CTE and some of the implications in individuals' lives. So it's definitely a very sad process. This table kind of highlights what I was just alluding to. So the CTE group, more commonly, so percentage-wise, 60% had co-occurring psychiatric disorders, and then alcohol or substance abuse problems, as well as 40% of the CTE decedents, the manner of death was by suicide. And a somewhat interesting aspect of this paper, I'll just point out for the relative risk, and as far as statistics, for those of you out there that are into statistics, I'll just mention it. So the individuals with TBI exposure that had CTE was 10 out of 60, and without TBI exposure or without playing contact sports, without a history of contact sports, was 0 over 165, which made the relative risk non-computable, which means the 95% confidence interval was 6.16 to infinity. So anytime you have a 0 in the numerator or denominator, obviously things as far as statistics are concerned are going to become quite complicated. And they go further into that down here. They talk about that a little bit more. So the discussion. So the differences in CTE frequency among football players as compared with the military series reported here may provide information regarding the extent of the population that CTE represents in the two populations, so contact sports and military personnel. So it kind of alludes to, at least in my opinion, that perhaps CTE is more of an issue in contact sports necessarily than military service. Obviously, you can't draw a conclusion just from one study. You're going to need more data. But if you just think about it big picture wise, I think it makes sense, right? So in football or other contact sports, it's essentially every play you're hitting someone with your head or you're being hit, and your brain is constantly getting jarred around. Whereas in the military, maybe your job in the military is like mine, and you're a pathology resident and you're rarely exposed to blasts or anything like that that could potentially cause a TBI. Or even if you are in the infantry or other jobs in the military, maybe your job doesn't expose you to blasts that often either. So it's really variable, but it seems like the frequency of head injuries or chance for head injury is a lot higher from what I gather in contact sports. So just something to think about. I'm curious what you all think as well, and just it definitely was thought-provoking for me. So in conclusion, the evidence of CTE was infrequently found in a series of brains for military personnel, and the findings that, or the brains that did have CTE, the neuropathologic changes were minimal. And then the risk ratios for CTE were numerically higher among decedents who did have contact sports exposure and other exposures to TBI in civilian life than among those who had blast exposure or other military TBI. But the small number of CTE cases and wide confidence intervals preclude causal conclusions. So as is often the case in science, so more data is needed, more studies should be done, but it's a step in the right direction and a good primer to get us thinking about this disease process. So some limitations of the study. So the study was underpowered as far as the number of brains to determine whether blast exposure was associated with CTE. And then accurate assessment of the TBI history was kind of challenging because, as is totally understandable, the history of TBI was largely relied on the knowledge and recall of family members because the service member had passed away. So a lot of the TBI history was accounted for by family members that may not have known all of the specific details of TBI exposure. And then all cases involved the brains of male service members. So obviously, in any study like this, you would want to see brains of females as well. So that is clearly a limitation of this study that more data could be quite useful for. These are my references, and then obviously when I give the talk I'll have a slide for questions, but if any of you have questions, I'm not an expert, I'm just a second-year resident, and I'm trying to learn more. I haven't had a neuropathology rotation yet, but I do want to go into the field of neuropathology. And if you have any questions, feel free to put them in the comment, or if you have any comments or criticism, this is me and some of my co-residents in the Army, and we were at the range last week and had a good time, able to get out for a half day. And then my colleague, Dr. Wong, on the far left, he's actually the co-founder of Pathagonia in this channel. So him and I have been having a lot of fun making these videos, and I hope you've been enjoying them. Thank you.